it's Dr. Jack with the Psychopharmacology Review. This is the part one out of three of our three-part series, and this is a very high-yield presentation. There are a lot of questions on the exam related to psychiatric medications, of course, so let's dive right in. And we begin with an introduction, and then I go into pharmacokinetics. So introduction. Efficacy versus effectiveness. So this is one concept we need to know. It's very simple, but it is tested. And there are two terms we need to learn. Efficacy, this is how well a medication works in an ideal setting. What does that mean? It means that the patient or the group of patients taking the medication are doing so exactly as prescribed. So there's 100% adherence or something close to it. So when we're assessing the efficacy, right, the benefits that are provided by medication that's taken exactly as prescribed. Now, this does not usually happen in the real world. This happens in research studies, and even there, it's a challenge. Now, the other term is effectiveness. This is how well a medication works, the benefits it provides in the real world, including all of the problems that patients have maintaining their adherence. So, missed doses worsen with increased complexity of dosing schedule, with the rate and severity of adverse effects, the need to follow additional instructions, for example, like take it with meals or avoid it right after meals, what have you, and with higher costs. Therefore, we can't increase the efficacy of a drug because we didn't develop it, but we can increase the effectiveness of that drug for our patients by increasing their adherence to that drug. How do we do that? We simplify the regimen. First of all, we want to discontinue ineffective medications. They're not adding anything there. They could be increasing adverse effects and just complicating the schedule. Then we want to simplify the schedule. We want to, if we could give once a day dosing medications, that's better than 2 or 3 times a day dosing. So we want to use extended release or long-acting formulations if clinically appropriate, and then consolidate dosing. So, at least in hospitals, sometimes when you give a medication BID, that means 7 a.m. and 9 a.m. and 5 p.m. While Q12 means 7 a.m. and 7 p.m. So two medications given twice a day, and it leads to like 4 total times where the patient has to swallow a pill. So we can consolidate that to once in the morning, 2 pills at the same time in the morning, 2 pills once in the evening, or preferably all of the pills that the patient takes once a day. It can make a really big difference in terms of increasing effectiveness up to its, kind of theoretical efficacy limit. Now, the way I remember these two terms is, I think about effectiveness, and it's how well the medication works in the real world, and it's also, to me, the more real-world word, right? I don't usually go around, with the word efficacy on my lips. But effectiveness, that's something that we use in normal English. So that's the real world word, and that's the real world concept. Now let's go on to number needed to treat. It's a measure of the clinical benefit that represents the number of patients who would need to be treated to prevent one additional adverse event. An adverse event could be, maintenance of depression, continued depression. It could lead to relapse of a patient who's remitted from a depression and now they relapse back into it. So whatever that adverse event is. And the number needed to treat is calculated by taking the reciprocal of the absolute risk reduction between 2 treatments. So the absolute risk reduction is the difference in reducing risk of adverse event between 2 treatment options. So, how effective is treatment 1 in reducing the risk of that adverse event, and versus the risk reduction of the second treatment, and then we can subtract one from the other and therefore get their difference. And so the NNT is calculated by having 1 over the absolute risk reduction. And I'll show exactly how this works to kind of bring it down to earth. Now, what is an adverse event? Well, that remains to be defined, whatever you're looking at. So number 1, it could be failure to prevent a relapse, for example, a future depressive episode, or development of some sequela of a depressive episode, like a suicide attempt, right? Or it could be lack of response or remission to treatment of an existing disorder, such as a current depressive episode. And the lower the number needed to treat, the more effective is the treatment. Because again, if it doesn't take that many patients to treat to get one additional patient to benefit, we want that number to be small. We'd rather only have to treat like 3 people in order to get one additional patient to benefit from that treatment compared to the other one, as opposed to having to treat 10 additional patients for one, or 10 patients for one patient additionally to benefit from that treatment compared to the other one. So right away what we need to notice is that the number needed to treat is always the comparison of one thing to another. What is being compared? Well, it's going to be whatever the treatment option you're interested in perhaps recommending, or you're testing, researching it. So that's going to be your treatment. Now, what could it be compared to? Well, it could be compared to another active treatment. So maybe you're researching a new antidepressant and you want to compare it to an existing antidepressant, or that comparator could be a placebo, so it's a pill. A patient thinks it's a real medication, but it's just placebo, because placebo usually has a benefit. It does reduce risk, even though it's could be a sugar pill. The comparator could be treatment as usual. In research studies, it could be a wait list condition, or it could just be nothing at all, no treatment, no outreach, or anything. So you're always comparing the reduction in risk of one thing, one treatment option, to another treatment option. So let's look at an example here to bring it down to earth. You'd like to treat a patient who's in remission from a depressive episode with an antidepressant. You want to provide maintenance treatment, prophylaxis against a future episode of depression. Now the patient wants to know how effective this prophylaxis is, because you say, well, this might be long-term. It may be a matter of years. The patient says, well, it kind of upsets my stomach. I've gained some weight from it, and it affects my sexual functioning. Is this really going to help me, Dr. Jack? And so let's say I have the following data. And this is, by the way, made up. It's not real. I'm just giving this as an example. Let's say what we know about maintenance treatment for depression is that the 3-year relapse rate on no antidepressant is 75%. The 3-year relapse rate when the patient is on an antidepressant maintenance treatment, it's 45%. So then step 1, I calculate the absolute risk reduction, the relapse rate in the no medication group versus, minus the relapse rate in the antidepressant, the medication group. And so from our example, that's going to be, I convert the percentage into a decimal number. So 0.75 minus 0.45, right? That's the relapse rates for those two conditions, and I get 0.3, right? And again, the absolute risk reduction is a measure of the difference in relapse rates between the two options, the two treatment options. And then step 2, I just have to take, the reciprocal of that. So what I do is I take 1 over the absolute risk ratio, which in our case is 0.3. So it's 1 divided by 0.3, and what do you get? 3.3333, right to infinity. So we normally will round it to the nearest number is 3. So you can then tell the patient, well, look, it's reducing, being on maintenance treatment is not going to be, it's not going to eliminate your risk of relapsing to depression. There's no perfect treatment, but it will reduce the risk. So for example, if we look at 3 patients on no treatment, perhaps only one of them will remain risk-free from depression on no maintenance treatment, while on the people with the maintenance treatment, 2 out of the 3 will remain on kind of free of the depression. So that's pretty good odds. That makes a big difference. Now let's turn our attention to the number needed to harm. It's the average number of patients who need to be exposed to a risk factor, such as to a medication with potential adverse effects, for one additional patient to be harmed, to develop a particular adverse effect, as compared to patients treated with a comparator treatment. It could be an active control, a placebo, or no treatment. So if you treat depressed patients with an antidepressant that has a number needed to harm of 10, it means that when you treat 10 patients, excuse me, one additional patient will develop that adverse effect as compared to patients receiving that comparator treatment. Now, in this case, it's the higher the number needed to harm, that's better. That means that the treatment is safer, has lower adverse effects, lower toxicity, what have you, whatever it is that you're looking at. So now let's look at other relevant concepts that we need to know just for exam purposes, and they're obviously clinically relevant too. So bioavailability. Bioavailability, it's the percentage of a medication that enters the systemic circulation. It then becomes bioavailable to affect the body and at its site of action, at that drug's site of action. But bioavailability differs by route of administration. So the problem with taking pills orally is that their bioavailability is often quite low. Why is it quite low? Because of the first pass effect, which you probably remember from medical school or residency. So when a drug is administered orally, it is absorbed from the gut lumen, right, and sent to the liver via the hepatic portal vein, and that drug is metabolized there in the liver before it even gets into the systemic circulation. Thus, it leads to a reduction in the concentration of active drug that enters the systemic circulation, and thus a lower concentration that will eventually reach its site of action. So the first pass effect is very important, and therefore you can take advantage of that effect by perhaps developing and then prescribing a prodrug, which actually becomes bioactive once it is metabolized through the liver. So you're taking advantage of the first pass effect. Now this is also why some drugs are, because of the huge first pass effect that would occur, they're given through other routes. Sublingually, intranasally, it could be suppositories, it could be IV, it could be a patch on the skin. So this is why there are all these other routes of administration. Now moving on to another concept, the related concepts of effective dose, toxic dose, and lethal dose. So the concept of an effective dose, 50, ED 50, this is a dose at which 50% of people will experience a therapeutic effect. You may also be interested in thinking, well, okay, but 50% of people responding, that's still kind of low. Like, what would be a dose where almost everyone responds? So, you can also look up on the table, on graphs, like the ED 99. That would be a dose at which 99% of people will experience the therapeutic effect. For example, toxic dose 50, that's the dose at which 50% will suffer a toxicity, the TD 50. And then we have the lethal dose 50, LD 50. It's a dose at which 50% of people will die exposed to that dose of medication. And then we have the therapeutic index. This is where we compare these doses to each other, and we're going to be comparing the toxic or lethal dose to the effective dose, and look at the ratios there. So the therapeutic index, most commonly, we're going to be comparing the TD to the ED 50. So it would be the toxic dose 50 divided by the effective dose 50. And the higher the number we get after calculating the ratio, that means the safer the medication is. And there are medications that have a very a very narrow therapeutic index, a small therapeutic index, and we need to know them, like lithium, barbiturates, pimozide, digoxin, levothyroxine, warfarin, and flecainide. So this means when something has a low therapeutic index, that means the toxic dose is not all that much higher than the effective dose. You can also compare the lethal dose to the effective dose, 50, and then, that is the ratio. How much higher does the dose have to be to lead to, potentially to people's death as compared to the effective dose? So let me give you an example. Let's say I prescribe a medication that has an ED 50 of 5 milligrams, effective dose 55 milligrams. Now, let's say it's toxic dose 50, its TD 50 is 25. Now, let's say there's another drug, antidepressant B, has an effective dose also of 5, but its TD 50 is 100. So, which one is going to be kind of safer to prescribe, less likely to lead to toxicity? The second one. So for the first one, if I take the TD 50 of 25 and divide it by the ED 50 of 5, I only have a therapeutic index of 5. In the second case, the TD 50 is 100 and the ED still is 5 in that second example. So I would divide 100 by 5 and get to 20. So definitely the second drug is less likely. The patient would have to, take a lot more of that medication, that drug, in order to develop toxic effects. And the same thing with lethal effects. So I want the lethal dose 50 to be very high. So maybe the lethal dose over the effective dose may be like 100 or maybe 500. And then this would mean that even if a patient, intentionally swallowed a full month's worth of medication, it still would not likely lead to their deaths. With a very high ratio of lethal dose to effective dose, it could even be that the patient could be, kind of planning and kind of, hoarding medications and then just take so much. Again, with a high therapeutic index, that would be okay, because that patient may, even to their most effective ways of trying to overdose, would still be unlikely to die, because they'd have to take maybe 500 times a daily dose or something like that. So therefore, it's important to note the opposite, the ones that have a low therapeutic index, a narrow therapeutic window. Again, it's going to be lithium, barbiturates, pimozide, digoxin, levothyroxine, warfarin, and flecainide. All right, now let's look at the biological effects of drugs. They are dependent on the drug's pharmacokinetic profile and its pharmacodynamic profile. Now this is dependent on that molecule, the drug, how it looks, and then how the body processes it pharmacokinetically, and then what effect it has on the body at its site of action. Right? For us, it's going to be somewhere likely in the brain. But of course, the same drug, that same chemical, can act very differently in different people, because there are these individually relevant factors that I'm going to go over. Before we do that, let's review what adverse drug reactions are. So first, they are due to the drug's biological effects. The ADRs are most serious in drugs with narrow therapeutic windows and then low therapeutic indices. Now, a major cause of ADRs are drug-drug interactions. Now, a drug can be It may be the only drug given that the patient is taking. So you can have an adverse drug reaction just with a single drug. It does not depend on drug-drug interactions. Drug-drug interactions just make that adversity, that effect, more likely. So now let's look at the individual factors that affect a drug's biological effects, right? So there are factors that differ among and within individuals. The differences among individuals are, that people differ markedly from each other on factors that impact the drug's biological effects, right? Some people are slow versus rapid versus ultra-rapid metabolizers. But there are differences that occur within the same individual. People experience bodily changes over time that impact the drug's biological effects. So now let's look at these factors. There are five types of factors. Number one are the genetics. There are slow versus rapid versus ultra-rapid metabolizers. So there are genes in our bodies, that are the same, exact same DNA sequences in every single human on the planet Earth, and even maybe these are, the same exact genetic sequences, DNA sequences in other mammals, for example. So the majority of our genes are the same exact genes across everyone. But there are a certain number, a substantial minority of genes that come in different forms. And I might have one form and you can have another form. And these are called, the different forms are called alleles. And then, genetically these are polymorphisms. And a morph is just a form, a different form, right? So polymorphism means that a gene comes in kind of different. There's slight differences in the gene leading to slight differences in its gene product. In this case, these enzymes, right? So this is why we differ, because the genes that code for these, for example, CYP450 enzymes, differ among people. Also age, this could be within person a factor. A safe dose at a certain age can become toxic at an older age. I've had many patients over the years that, perhaps they were started on like diazepam when they're 40 years of age. They're taking 30 milligrams total by the time they came to me when they were 75. And what might have worked for them when they were 40 could be quite dangerous and lead to serious adverse drug reactions now when they are 75. They could be overly sedated, get into motor vehicle accidents, they may be uncoordinated, their gait may be disturbed, they're at high risk of falls. Disease states, again, these differ between individuals, but also within an individual over time. A person could develop hepatic or renal disease. There could be lower perfusion to these organs. And there could be inflammatory states. There could be changes in albumin serum levels that can affect free drug levels, which are the bioactive drug. So when you are bound to a protein, plasma protein like albumin, you're not going to be biologically active. You got to be free drug. Now there are other mechanisms in the body that sometimes can counteract these changes in free versus bound drug levels, but still there's going to be some effect. Number 4, environmental changes. A patient's nutritional status at that time, hydration level, and exposure to environmental toxins and pollutants. And then of course drug-drug interactions are going to affect how any one drug is affecting the body and affected by the body. Here's a definition of a significant drug reaction. It's any unexpected, unintended, undesired, or excessive response to a drug used at a normal dose that will lead to any one of these. It requires discontinuing the drug, requires changing the drug therapy, requires modifying the dose, necessitates admission to a hospital, prolonged stay in a healthcare facility, necessitates supportive treatment, significantly complicates diagnosis, negatively affects prognosis, and results in temporary or permanent harm, disability, or death. So this is quite a range, you know. On the one hand, you know, it could, at the most severe, significant adverse drug reaction could result in death. On the other hand, less severe, just requires us discontinuing with the drug. So, you know, there are many patients who can't tolerate a drug and ask for it to be discontinued or just do it on their own. So significant adverse drug reactions are common. Now, who are the patients who are at highest risk of developing a significant ADR? Well, the patients on polypharmacy. Why is that? Because there's higher chance of any one of these occurring, that at least one of the drugs will cause adverse drug reaction just on its own. But also because there's going to be likely higher occurrence of a pharmacokinetic drug-drug interaction and or pharmacodynamic drug-drug interaction. And we'll go over those in more detail in a later section of this presentation. Also at higher risk are patients who have comorbidities, both medical and psychiatric, partly due to the disease state and partly because they're going to be on most likely more medications. Elderly patients, especially those over 80 years of age, frail patients, females, who on average women have slower metabolism and excretion, patients who are cognitively impaired, malnourished, who are post-surgical in an ICU or on a burn unit. So as prescribers, it's going to be important for us to do what we can to decrease ADRs. And there are things we can do prior to prescribing a drug and then after prescribing it. So before prescribing, we want to review the entire medication regimen as it is now before we prescribe, including any over-the-counter medications the patient's taking or supplements. We want to review a history of prior medication responses and the adverse drug reactions that occurred with those. We obviously want to avoid prescribing again medication that patient had adequate trial with and then failed it or could not tolerate it. We want to review full medical history, cardiac, hepatic, and renal disease in order to, avoid any significant ADRs. We want to establish clear target symptoms so then we can monitor the patient's response and then act accordingly. If the patient doesn't respond, we're going to do something, increase the dose, or eventually discontinue the medication. And of course, we want to deprescribe all existing medications that have unclear or no benefit. A lot of these are going to be prescribed by other prescribers, and so we're going to need to coordinate that because we don't want to stop what someone else is prescribing without their input or without them taking the initiative. And then there are two instruments that guide the physician, the prescriber, to again kind of use medications, prescribe them in the most beneficial way, and they are the STOP instrument. It stands for Screening Tool of Older Person's Prescriptions, and then the START Screening Tool to Alert to Right Treatment. We don't need to know details, but just know that those exist. And then we want to monitor for after prescribing. We then want to continue monitoring that patient for any adverse drug reactions that occur. We want to monitor for proper adherence. We want to make sure patient is not missing doses or doubling them. We monitor for addition of new medications to the regimen prescribed by some other prescriber, because that could lead to drug-drug interactions. And then when available, we can obtain blood levels. So, for example, some drugs have very clear therapeutic therapeutic plasma levels of that drug that could be assessed. They include the tricyclics, amitriptyline, nortriptyline, imipramine, desipramine, and also clozapine is one that's often also monitored through blood levels, as well as obviously many of the mood stabilizers.